everybody, and let's jump straight into the vertebral column. All right, let's go through the types of vertebra first. So the cervical vertebra is defined by their bifid spinous process, as you can see, there's two prongs, and by the transverse foramen right here. The thoracic vertebra is defined by their long spinous process, a fairly large vertebral foramen, and a mid-sized body. The lumbar vertebra is defined by their larger pedicles, their robust bodies, and a smaller, squatter spinous process. It's really defined here in the lateral view. Look here. This is the spine. This is the bifid process on the spinous process. Here is the transverse foramen. Pardon me. This is the spinous process. Look how long it is, and there are the facets for the ribs. When you look at it head-on posteriorly, it always looks like a giraffe to me. So that's how I remember that is a thoracic vertebra. And in the lumbar region here, look, there's the thick body, the squat spinous process, and if you look straight on, it looks like a moose. Here are the special vertebra. This is C1, this is the atlas, and it articulates with the skull, and this is C2, and it inserts into C1. This is the axis, right? Let's go through it. The atlanto-occipital joint is where the atlas articulates with the basilar portion of the occipital bone right here. And the atlantoaxial joint are the articulations between C2 and C1 with the transverse processes, and with the dens, that's where it gets 3 joints. And the most superficial is the anterior longitudinal ligament, and see, it covers the body of the vertebra. And then the anterior atlanto-occipital membrane is just the continuation of the anterior longitudinal ligament. Deep to that is the membrana tectoria, right here, and deep to that is the cruciate ligament. And the cruciate ligament is what holds the dens in place. Deep to the cruciate ligament, we have the apical ligament and the alar ligament. So that also holds the dens in place, but mostly it is right here. This is the transverse ligament. All of this allows the atlanto-occipital joint to flex the neck and extend it, and laterally flex it, which is to cock your neck from side to side. And the atlanto-axial joint allows for head rotation. Let's go through the injuries. So the injuries to the dens, you can see it with an x-ray, but you must ask the patient to open their mouth to see the x-ray correctly. Look here. So this dens has been displaced to the right laterally. Usually it should be straight up, and in here, this is a pretty good image. It has been displaced. Here you can even see the fracture of the dens. This happens because the transverse ligament is stronger than the dens, and the dens will fracture before the ligament tears. These fractures are unstable, and there is a risk of avascular necrosis, because if this has fractured completely, there isn't a way for the body to reunite the bones, right? That's because the transverse ligament will go in between the bony pieces, and there isn't really a way to heal this besides surgery. The rupture of the transverse ligament can occur alone, or with the atlantoaxial subluxation, or with a atlas fracture. and it's caused by usually a whiplash injury, car accidents, but in some cases, the pathological softening of the transverse and adjacent ligaments can also result in the subluxation. And this is quite dangerous because in the spinal cord, there's a high risk for a spinal cord injury. Look here, this is an MRI. You can see the dens is displaced, and you can see the fractures. Right, so the intervertebral joints, they are symphysis joints. They have the hyaline caps right here, and the fibrocartilaginous intervertebral disc. Disc come all the way from C2 to the sacral region, and it makes up a fourth of the vertebral column, and they are the thickest between the cervical and the lumbar region. And the discs are made out of the annular fibrosis, which is rings of fibrocartilage, and inside is a nucleus pulposus, which is hydrated proteoglycans. And it's larger in kids and teenagers, and as we age, it will, shrink in size. Let's go to the hernias. If the annular, let's go back a little. So if the annular fibrosis is ruptured and the bone has been, broken, the nucleus pulposus can be forced out, compressing the spinal cord or any of the spinal nerves. Let's go back. There are two regions that is particularly prone to this. It is the cervical thoracic regions from C5 and 6, and the lumbosacral region L4 and 5. And they can rupture posteriorly. So they protrude in the midline. It will go under the posterior ligament, longitudinal ligament, and if it protrudes to the side, it will protrude close to the intervertebral foramen in like C, in the C region, cervical, cervical region. And there's a couple things that we need to take into consideration at the sites of the herniation. So in the cervical spine, there is only the exiting nerve. So the disc will affect the same nerve root. And it's different in the lumbar spine. In the lumbar spine, there's a mismatch because there are an exiting and a transverse nerve. So in the cervical herniation, let's see. So under C6, this is the C6 to 7. If it herniates, it will rupture. It will compress. It will compress C7. If the herniation is in like C6 to 5, it's gonna herniate and compress the cranial, the cervical nerve 6. The Schmorl's nodule is just if the vertebral disc like herniates into the vertebral body, like it would dip into here. Let's describe the herniation a little bit more. Here, this is the exiting nerve, and this is the transversing nerve. So if the L4 to 5 disc herniates posterior laterally, it's going to be compressing the L4 nerve, the nerve above. And if it compresses posterior medially, it's going to be compressing the L5 nerve. If this was C4, it would herniate and compress C5. But there are two ways that it can herniate in the lumbar region. Oh, I hope that made sense. Okay, so when we age, we lose the water content of the nucleus pulposa, and the elasticity of the disc degenerates, and it's replaced with the fibrocartilage, and over time the collagen fibers will degrade and degenerate and eventually get compressed. There are several ligaments right here. This is the anterior longitudinal ligament. See how it attaches to the bone and the intervertebral disc. This is the strong, wide ligament, and deep to the body is the posterior longitudinal ligament. Here it is. It forms this kind of shape. It is behind the vertebral body. There's a couple other ligaments we should pay attention to right here in between the spinous processes. This would be the ligamentum flavum, and connecting the tips of the spinous processes, that would be the supraspinous ligament. The interspinous ligament connects the spinous processes together, and the intertransverse ligament connects the transverse processes. And you can't really see it, but the supraspinous ligament will extend all the way up and connect to like the nuchal ligament. So in these injuries, spondylolysis is the forward displacement of the vertebra. Spondylolisthesis is generally in the lumbar region, and that is where the entire bone will be fractured and displaced. They're usually in the elderly. Occasionally it is congenital, and there's a defect in the pedicle. Then it causes the degeneration anterior slippage, and they cause the spinal cord, the vertebral column, to be unstable, and lumbar nerve compression. And it involves generally the fracture between the pedicle of the vertebra. And Luschka joint is also known as the uncovertebral joint. Here is the uncus up here, and here's the vertebral body. It does have a capsule. It is a synovial joint, and these sites are generally frequent sites of spur formation. That's next, the Zygapophysial joints. They are between the superior and the inferior, inferior articulate processes. It is a synovial joint, so it has hyaline and a capsule. And if there is injury or disease, it will cause dermatomal pain. So remember the dermatomes, the pattern, how those spinal nerve innervate patterns on the the skin layers, all the way up to the skin, the epithelial. Oh my goodness. Skin layer that will cause those like patterns of pain, and those can be managed with a steroid or local anesthetic injections, or with the section of the resection of the nerve, so that's the rhizotomy, or it can be lysed with the radiofrequency percutaneous rhizolysis, and that's where the root of the nerve will be dissolved. Here are our accessory ligaments, which I have described before, but this shows a better picture. Here's the nuchal ligament and how it continues with the supraspinous ligament. And the spinous ligament would be in between right here. You couldn't see it as well in this picture, but it would be in between the spinous processes. Alright, here's the movements. Nerve supply. The intervertebral joints are innervated by the meningeal branches of the spinal nerves from the posterior rami. And the joints of any levels have nerve fibers from this is not really like two separate spinal nerves. It's just like two branches of the same spinal nerve. See how it like goes to the right and to the left. Let's go through the blood and veins really fast. The cervical is supplied by the vertebral and ascending cervical arteries. Thoracic have the posterior intercostal arteries because, you know, this is where the ribs are. The abdomen is supplied by the subcostal and the lumbar arteries. Pelvis, iliolumbar, and lateral and medial sacral arteries. The internal vertebral epidural plexus is the venous plexus that drains the vertebra, and the basovertebral veins drain into the external and internal plexuses, and from there the intervertebral veins receive veins from the spinal cord and the internal external plexuses, and they drain into the vertebral neck veins, like all the way up in the neck, and in the segmental trunk for, like, you know, the thoracic region. Right, so there's two curves that we should know, the fetal curve, adult curve. So in utero, the fetus is all curled up, and that is what causes the thoracic curve and the sacral curve. The adult curve forms when we begin to stand. So first, babies will lift up their head, forming the cervical curve. And to compensate for that, the lumbar will curve. So we are able to stand straight up because we are a bipedal species. All of these curves just compensate for our center of gravity. Scoliosis, of course, is the abnormal curvature of the spine. So instead of like a nice vertical straight line, it will be curved slightly like as an S. In severe cases, it can be like almost a C or a complete S shape. So here are the injuries we should know about. The disrupted, you can't see it as well in this particular MRI, but here it goes like side to side, right? So that is the disrupted injury. Perched, here you go, is the perched injury. And locked is when the superior vertebra is thrust below the inferior vertebra, and these generally are in like very, very bad accidents. Look at this man's, or not man, but this person's spine. Like a locked vertebra is not just his problem. Like here, the fractures. All right, let's go through the fractures real fast. Jefferson's fracture, they occur diving like headfirst in a pool, and it is a C1 atlas injury. See how it breaks here? Here, fracture. Hangman's fracture happens with hyperextension, and it is a C2 injury. Look here, here's the fractures. There are the flexion fractures and the extension fractures. The flexion fractures are the most acute, severe. It generally happens in the lumbar region. Oh, look here. They're described. They're characterized by having teardrop fractures of the bodies. Here's the fracture, and here the spinous processes are all messed up. And the extensions fractions, they generally are in the cervical region. It's not as severe. And here, there's the teardrop. Chance fractures are when the anterior longitudinal ligament is torn along with like the interspinous, the intertransverse, all the way into the body of the vertebra itself, and that is broken. As you can see, by far is worse are the translational injury, because these generally cause a paralysis. Well, that's it, and thank you for your attention, and good luck.